And with that, we will move on to the next session for today. And for that, to take that forward, may I please request Dr. Aftab Khan, Dr. Ashok Parida, Dr. Oshit Das, Dr. Azizul Haq, and Dr. Orindam Pandey to join the session and to begin with it as the respected panelists and chairpersons. The first speaker for this session would be Dr. Orithro Konar. I can see that we already have Dr. Konar with us. So requesting any one of the chairpersons or the panelists to offer the baton to Dr. Orithro Konar to begin with the next session.
Yeah, so this is Dr. Aftab here. So as a chairperson, I cannot see Dr. Parida. I hope he's joined in also. And just following up with the second session as a follow-up of the first session, here we have a clinical scenario that's been presented to us. This is a 45 years old male who's an ex-smoker. He's a non-diabetic having recurrent heart failure hospitalization despite being on, I don't have slides actually. This is the background of the setting of the patient that we are talking about. So the slides are not there, but you can understand that this is a patient who's a 45 years old gentleman. He's an ex-smoker, non-diabetic, recurrent heart failure hospitalizations despite being on optimal medical therapy. And he's in sinus rhythm. And he has an ECG which suggests a complete left bundle branch block with a QRS of 140 milliseconds. His echo reveals an old anterior wall myocardial infarction with an ejection fraction of 28%, and his RV function is normal. This gentleman has been catheterized, and he has an angiography which reveals an osteoproximal occlusion of the left anterior descending artery, and his other coronaries are normal. He has a creatinine of 1.5. So take this discussion ahead. We'll have three talks. The first one is from Orithro Konar, who will be talking about medical stabilization and what more we can do beyond the four foundational drugs in this young gentleman with a left bundle branch block, with an ostial LAD total occlusion, and with severe LV systolic dysfunction with normal RV function. So Orithro, I think you can begin your talk, and you have 15 minutes, and I think we'll request you to please stick to time so that we have time for discussion also.
Thank you so much, organizers. Dr. Khan here, the chairpersons, and all the organizers, particularly Dr. Shubhra Banerjee and everyone, for giving me the opportunity to be a part of this. And it's a pleasure to be here and the part of this forum. So already as has been introduced the case scenario by Dr. Khan, and let me share the screen.
Yeah, I think.
Okay, that will be better.
Yeah, I think that would be better. You mail the presentation, and in the meantime, I think we can have the second speaker first.
Yes. So Dr. Rana Rathore, whilst Orithro is getting his mail across, I think he can then take the talk on the scope of CRTP versus CRTD in this gentleman who has an airway dysfunction with a left bundle branch block and is in sinus rhythm.
Yeah, good afternoon. Am I audible?
Yes, you are audible, and your slides are also seen.
Yeah. So thank you, everyone. And at the outset, I would like to thanks Dr. Banerjee for giving me this opportunity. Today, this is about a case scenario, and that is about 45 years old male who is ex-smoker, non-diabetic, who is in sinus rhythm, left bundle branch block, and he is having QRS duration of 140 millisecond, and he is also having old anterior wall MI. His ejection fraction is 28%. And his also history of recurrent hospital admission for heart failure. So if you look at this case, it's a gentleman, 45 years old, ex-smoker. That means he had risk factors for cardiovascular disease, and he's in sinus rhythm, left bundle branch block, and QRS duration is 140 millisecond, although it is less than 150 millisecond, but this is more than 120 millisecond. And his ejection fraction is 28%. That means it is less than 35%. And he's a known case of ischemic heart disease. And along with that is history of recurrent hospital for heart failure. Now coming to that, whether this case is suitable for CRTP or CRTD. Now the question is, what is the need for a defibrillator for primary prevention in patient indicated for CRT? So if you see this case, who is a 45 years old male, he is a sinus rhythm, left bundle branch block, his QRS duration is 140 millisecond, his ejection fraction is 28%. That means definitely this fulfills the criteria for CRT. Without any doubt, also it is a class 2A indication, not class 1, because of its LBP morphology. If it's more than 150 millisecond, had it been, then it is a class 1. but since it is 120 to 1 less than 150, so it is a class 2 indication definitely. So this is a case for CRTP. Now the question is whether this is a candidate for ICD or not. Yes, if they just see the primary prevalence on ICD, yes, this fulfills the criteria for primary prevalence of ICD. Now what about the CRTD? Now the question is need for a defibrillator for primary prevention patient indicated for CRT. CRT therapy per se reduces the risk of ventricular arrhythmia and sudden cardiac death mainly through the reverse LV remodeling. So it is not that CRT therapy is only helpful for heart failure hospitalization reduction or for heart benefit. It also reduces the sudden death because of reverse remodeling. And rates of sudden cardiac death have dropped in the last 2 decades as evidence in pivotal heart failure medication and CRT trials. And after the coming of the ARNI and SGLT2 inhibitors, new heart failure medications such as ARNI and SGLT2 inhibitors, when added on top of established heart failure medication, reverses LV remodeling and reduces ventricular arrhythmia compared with controls. So although guidelines are clear about ICD indications, they also stress using clinical judgment when deciding on the primary preventive ICD in patients indicated for CRT. So we have a clear-cut guidelines for CRT, isolated CRTP, or as well isolated ICD. But when there is question of CRTD, there is some jugglery of guidelines. So this is not surprising since CRTD is both more complex and associated with a greater risk for complication, inappropriate ICD therapies, and anxiety for the patients. These issues are there with CRTD. Now, if you see the CRT guidelines or indication for CRT, so any patient with heart failure on guideline-limited therapy for more than 3 months and more than 40 days after MI, see the LV ejection fraction, and if ejection fraction is less than 35%, and if the NYHA class 2 to ambulatory class 4, then if it is the LVB morphology and is the QRS duration is 150 millisecond, more than 150 millisecond, it is the class 1 indication for CRT. And if it is LVB morphology but QRS duration is 120 to 149, then it is a class 2A indication. But when it is a non-LVB morphology and if QRS duration is more than 150, then it is a class 2 indication. But if it is a non-LVB morphology with duration of QRS 120 to 149, it is a class 2B indication. That means whenever the ejection fraction is less than 35%, if LVB morphology more than 150 millisecond, we can go. If 120 to 149 QRS morphology LVB, we can go. And even in non-LVB, if QRS duration more than 150, we can go for CRT. But yes, if in non-LVB morphology 120 to 149, we should discourage CRT. We should not go for CRT. So that is about the class 1 indication of CRT in a heart failure patient is having ejection fraction less than 35%. Now coming to the indication of ICD, we all know that this is all in guidelines by the ACC-AHA 2022. In patient with non-ischemic dilated cardiomyopathy or ischemic heart disease at least 40 days post-MI with LV ejection fraction less than 35% and NYHA class 2 or 3 symptoms on chronic guideline-led community therapy who have reasonable expectation of meaningful survival for more than 1 year, ICD therapy is recommended for primary prevention of sudden cardiac death to reduce mortality. So there is no confusion regarding the ICD indication in patients who is a non-ischemic dilated cardiomyopathy or post-MI 40 days if the ejection fraction less than 35%, NYHA class 2 and 3, and if expected survival more than a year, we can go for ICD therapy as a primary prevention. Now coming to the patients who have ejection fraction less than 30% after post-MI, 40 days post-MI and NYHA class 1, even those patients, we can go for ICD as a primary prevention. Now coming, what about the recommendation for adding a defibrillator with cardiac resynchronization therapy? So patient is indicated for cardiac resynchronization therapy, and if you want to defibrillator, what is the indication? That is by the European Society guidelines. In patients who are candidate for an ICD and who have CRT indication, implantation of a CRTD is recommended. That is a class 1 indication. But what about the patients who are candidate for CRT? Implantation of CRTD should be considered after individual risk assessment and using shared decision making. That is the class 2 indication. So what about the sudden cardiac death in heart failure? How common is the sudden cardiac death in heart failure patients? The overall mortality rates and absolute rates of sudden cardiac death increases with worsening severity of heart failure, but the proportion of sudden cardiac death to total deaths decreases with worsening heart failure, NYHA functional class. In other words, with worsening heart failure severity, more deaths can be contributed for failing pump than the arrhythmia. So, if you see, if the merit heart failure trials, the 1 year mortality rates were 6.3%, in class 1, in class 2 NYHA, 10.5% in NYHA class 3, and 18.6% in NYHA class 4. That is about the 1 year mortality. But if you see the sudden cardiac death, it is 64% in NYHA class 2, it is 59% in class 3, and it is 33% in NYHA class 4. That means in NYHA class 4, sudden cardiac death is 33%, but in NYHA class 2, sudden cardiac death is 64%. That means more sudden cardiac death in NYHA class 2 in comparison to in NYHA class 4. So this is a study about the primary prevention of sudden death, that is the ICD trials. All the trials we know, the MEDIT, MEDIT-MUST, MEDIT-2, definite sudden cardiac death, and Danish trials. And in all these trials, it has been shown that if after the implantation of ICD, definitely there was less sudden cardiac death in ICD arm in comparison to medical therapy versus other therapy. So definitely ICD is helpful for reduction of sudden cardiac death without any doubt as a primary prevention. Now coming to what about the So as we already discussed that whether it's a MEDIT-2 or it is the companion trial or is the sudden cardiac death or whatever is in all the trials, ICD has been shown to be reduction of sudden cardiac death. So ICD decreases total mortality in patients with systolic dysfunction of any etiology regardless of NYHA class function, whether it is so it is regardless of any etiology, we can say that ICD reduces the sudden cardiac death. And these trials is about the CRT trials. We know all these trials, but you see here, there is this all trials is with the CRT versus the optimal medical management. There is no head-to-head comparison between the CRT-P versus CRT-D. There is only one trial that is called the companion trial, where there were two arms. One was the optimal medical management, one arm was the CRT-P, and one arm the CRT-D. Although there was no head-to-head CRT-P and CRT-D, but yes, in companion trials there was two arms. One was the CRT-P and CRT-D, and in this trial it was shown that in CRT-D definitely reduces the sudden cardiac death. So what about the adding AICD to CRT indicated patients? This is a mortality benefit of CRT-D over CRT-P is still unclear, mostly because no head-to-head randomized controlled trials have been designed to compare these two treatments. So while CRT-D may further improve survival over CRT-P by reducing arrhythmia death, it does also add ICD-specific risks such as lead failure and inappropriate shock as well costs. So that is the problem with the CRT-D. So CRT-D was associated with significant risk reduction in all-cause mortality compared with CRT-P in patients with ischemic cardiomyopathy. However, this difference was not found in patients with non-ischemic cardiomyopathy. So as far as ischemic cardiomyopathy is concerned, definitely it goes in favor of CRT-D, but while it comes to the non-ischemic cardiomyopathy, there is still a dilemma is there. So what about the Danish study? This is the very recent study, and it around the 1,000 patients of heart failure and non-ischemic cardiomyopathy to receive either a primary prophylactic ICD or usual clinical care. But in this study, 58% of patients also had CRT in both groups, and this study showed that subgroup analysis showed that CRT-D was not superior to CRT-P in reducing the primary outcome of all-cause mortality after a median follow-up of 67.6 months. So that is about the scenario of ICD in non-ischemic cardiomyopathy. Now coming to in the large multi-center study of 50,000 patients, CRT-D was associated with significant lower observed mortality. And similar results were found in a recent propensity matched cohort where CRT-D was associated with a significantly lower all-cause mortality rate than CRT-P in patients with ischemic etiology and in patients with non-ischemic heart failure under 75 years old. And there is another certitude cohort study here also shown better survival in CRT-D versus CRT-P, mainly due to reduction of non-sudden cardiac death. And also in Italian multi-center CRT registry, the only independent predictor of mortality was the lack of NSAIDC. So there is a mixed results in different trials, and but overall we can say that definitely in some cases it is not superior, but in other trials definitely it reduces sudden cardiac death. What about the companion trials? Companion, as I said, there were two arms in 3 arms, but 2 arms, one the CRP and CRT-P and CRT-D. Companion is the only trials to randomize patients to CRT-P or CRT-D, but was designed to assess the effects of TRT compared to OMT. And it was not designed to compare CRT-D and CRT-P. And CRT-P was associated with a marginally non-significant reduction in the risk of all-cause mortality, whereas CRT-D was associated with a significant 36% reduction. And analysis of cause-specific mortality showed that sudden cardiac death was significantly reduced by CRT-D. This is about the extended care of heart trials, heart flow trials, and it was shown that even in these trials, we can see that in optimal duct therapy, it was the 154 days, but in CRT arm, it was 101 days. So statistically significant and statistically correct that CRT itself reduces the death, but yes, still there death is there in the CRT arm. So definitely, I think that can be overcome with the implantation of CRT-D. And what about the complications of CRT-D? Or you see in the companion trials, it is, if you see whether it is implant success or total implant time, moderate or severe adverse events, it is not really very significant if you compare CRT-P versus CRT-D. So it is, and particularly nowadays, the technical issue is not there as far as the procedural complication is concerned with the CRT-D versus CRT-P. Absolutely no difference in severe implant-related adverse events between device type. Adverse events are mainly associated with LP lead positioning. Now coming to this very recent trials, that is about the reset CRT study, and it was a German study. And it is here see the CRT-P patients 66.7 years older than CRT-T, comparable etiology of heart failure, and median follow-up 2.35 years. And but here it was shown that no survival difference between CRT-D and CRT-P after adjustment of age and in the other parameters balancing. So it was shown that the CRT-P and CRT-D both were comparable. So there is no added advantage of CRT-D over CRT-P. So coming to that, general predict when we have definitely we have to consider CRT-D, general predictors of IC defectiveness, age and comorbidities associated with the mortality that competes with the sudden arrhythmic death. Thus, the addition of ICD to CRT should be considered, especially in younger patients. Good survival prognosis, ischemic etiology, favorable comorbidity profile, and presence of myocardial fibrosis. If you see on the cardiac MRI, there is a significant myocardial fibrosis. Definitely, we consider of ICD. Now, coming to the CRT-P versus CRT-D, it is a patient and clinician as clinician shared choice. If you see the more age, we have, in the higher age, we have CRT-P, less is younger age, we have to consider CRT-D. More myocardial fibrosis, then definitely we should prefer CRT-D. And it is still, again, this chart shows that when you think about there is a sudden cardiac death is high, then definitely we have to think about CRT-D. And when the sudden cardiac death is less, then we can think about CRT-P. So the take-home message is CRT is a disease-modifying therapy which improves survival and reduces need for hospitalization. Over time, CRC also reduces the risk for sudden cardiac death in patients with incremental reverse remodeling. And when we thus need to ensure that our heart failure patients receive the 4 key heart failure medication indicated in the guidelines as an appropriate way. And owing to the complexity of the matter and the lack of clear evidence, it is particularly important that the choice between CRT-P and CRT-D is guided by a process of shared decision-making between patients and clinicians, taking into account the both medical facts and patient values. But always we should think that our patients should not also get all current standard medical therapy of whatever the 4 pillars of heart failure therapy. And after that, we have to think about CRT-P and CRT-D. Thank you.
Yeah, thank you, Dr. Rathore. I think you finished well in time, and that's wonderful.